An acute coronary syndrome. The heart is sick and I don't know why. What does it mean? Does it mean an infarction? Could be. Acute coronary syndrome, ACS, does it mean angina? Yeah. Is it an infarction? Could be. Unstable angina? Could be. Non-ST segment? ST segment? I don't know. Acute coronary syndrome means that you have some sort of chest pain that's ischemic in nature, and I'm not certain yet whether it's an MI. I don't have enzymes. So acute coronary syndrome, basically they're thrombosing. It could be unstable angina. Remember, unstable angina by definition was new pain, worst pain, rest pain, new pain, worst pain, rest pain. It could be an infarction without ST elevation. You could just have pain. Pain, go away, come again some other day. So pain, unstable angina, aspirin, heparin, beta blockers, oxygen, morphine, nitrates. But aspirin, heparin, beta blockers, aspirin, heparin, beta blockers. Non-ST segment elevation. Aspirin, heparin, beta blockers. What's the difference in the management of unstable angina and non-ST segment elevation MIs? Not much. They both should be catheterized. Third option, a myocardial infarction. What, therefore, is the difference between the management of the person who's having quote-unquote unstable or unstable angina, okay, non-ST segment elevation MI, and an ST segment elevation MI? Which of these people is going to get an aspirin? All of them. Which of them gets a beta blocker? Atenolol, metoprolol, metoprolol, atenolol, atenolol, metoprolol, metoprolol, atenolol, all of them. Which of these should get a statin? All of them. Oh yeah, oh yeah. So what's the difference? Well, what's the difference is this. You can't tell these apart without an EKG and enzymes. You can't tell them apart without an EKG or enzymes. Cannot do it. That's why we have the term acute coronary syndrome, because it means you have a person with ischemic disease and you can't tell them apart without an EKG and enzymes. Now, the only one of these that's different is stable angina, and stable angina is by definition a particular pattern of pain. It's a particular pattern of pain. And the particular pattern of pain has to do with whether it's been changing or not. Well, look at this location of the pain. You see how it's substernal or in the back? Substernal. Not left-sided pain, not right-sided pain, substernal. Substernal pain is ischemic. Left-sided or right-sided pain is generally not ischemic in nature. Unstable angina, non-ST segment, non-ST segment elevation MI, non-ST segment elevation MI. How do you tell them apart without an EKG? You can't. As a matter of fact, they could both have the same EKG. Okay, as a matter of fact, you can't tell unstable angina. What's the difference between these two? What is the difference between these two? Has to do with CK-MBs or troponins. A CK-MB and troponin here is normal, and here it's elevated. How do you tell them apart? Now, it's elevated here too, but at least you can tell them apart with an EKG. You can tell them apart with an EKG. The symptoms, remember, ischemic pain comes first. Sore, squeezing, tight, 10, 15, 20 minutes. I get an EKG and markers. The markers are troponin and CK-MBs. Troponins and CK-MBs don't begin to go up for 4 to 6 hours. The markers are normal. Well, I got a story like an MI, but I'm not making enzymes. I got a story like an MI, but I'm not making enzymes. That's unstable angina. I got a story like an MI, but I'm not making enzymes. That's unstable angina. Now I got a story like an MI, but no ST elevation. Wow. Positive troponins. That's a non-ST segment elevation MI. That's the difference. That's the difference. Aspirin, beta blockers, hesperin. Aspirin, heparin, beta blockers. What do? Aspirin, heparin, beta blockers. Now, you see this thing about unstable angina to non-ST segment elevation MI? People who have, by definition, you ready? Unstable angina, excuse me. New pain, worse pain, rest pain, A lot of these people go on to MIs later. New pain, worse pain, and rest pain. Now, you can't tell them apart based on physical. They might have an S4, you can't tell. Now, only half of patients have EKG changes, meaning that the ST or the T wave is not abnormal in an awful lot of people who have serious cardiac damage. Now, the worst thing about unstable angina, how do we know who's going to go over there? How do we know who's going to progress and get sicker? How do we know who needs to be catheterized? Catheterized. What's the biggest thing? The person has pain and the pain just won't go away. Pain, pain, go away. Come again another day, but it won't go away. Time to cath me, time to cath me, maybe angioplast me. Oh, I made positive markers. See that? The longer that pain persists, the more likely you are to progress. The worse the EKG, the more likely you are to progress. The lower the blood pressure, the more likely you are. It's like, oh my goodness, the big bad wolf. Oh, Grandma, what big troponins do you have? Oh, the better to infarct you, my dear. Oh, Grandma, what low blood pressure you have? The better to kill you with septic shock, my dear. Oh, Grandma, I think you should put in your cardiac cath introducer. Can I shave your groin? Oh, yeah, that would be fine. So therefore, how do you know who needs to go on to getting catheterized right now? And the answer is people who have pain that just won't go away. Hey, what are you going to do? Just stay in there? You gave me an aspirin, you gave me a beta blocker, you gave me heparin, you gave me aspirin, beta blocker, heparin, morphine, oxygen, nitrates, ACE inhibitors, statins, aspirin, beta blocker, heparin, morphine, oxygen, nitrates, beta blocker, statins. You gave me all that and I still got pain. I'm going to die here. Cath man, cath man, cath man, make me a dream. Make me the best angioplasty I've seen. Put in a stent so the guy can pay the rent. Oh, cath me, yes, cath me. Oh, cath man, I'm hypotensive now. I'm gonna be buried under a plow if you don't cath me. Ah, yes. That's it. Shave me and cannulate me. Oh, and the worst. You see all these things? Prolonged chest pain, markers, EKG changes. These are all people who are very sick, hypotensive. The worse you are, the more likely you are to need to be cathed. Low ejection fraction, these are being repetitive here. So the worse you are, what happens if you had previous bypass? Well, this is a person who's going to get sick again. Remember, you see diabetes? The sicker the heart, the more likely you are to need to have an intervention. The same thing with chronic renal disease, because renal disease means you can't tell if it's a false positive troponin. Troponins accumulate in renal failure. People with renal failure have higher troponins than other people. What are you going to do about that unstable angina? You're going to do this. You're going to give everybody an aspirin. Everybody gets an aspirin. Everybody gets an aspirin. Everybody gets a beta blocker. Everybody gets a beta blocker, an aspirin, and nitrate, and morphine, and oxygen. But only ST elevation with TPA. Less than 12 hours of chest pain and ST segment elevation. Remember, ST elevation only. If you have non-ST elevation, no thrombolytics. No thrombolytics. Everybody gets aspirin. Remember, clopidogrel's main indication, I get stented, clopidogrel. I get angioplasty, clopidogrel. I can't tolerate aspirin, clopidogrel. I can't tolerate aspirin, I get stented, I get angioplasty, clopidogrel. Clopidogrel. Now, antithrombin therapy is heparin. Heparin is the single biggest thing that you do in both of these. Heparin here, heparin here. And the reason that these both get heparin is that these are a coronary artery that's in the process of clotting. These are coronary arteries that are in the process of clotting, of closing off. Heparin prevents clots from forming. Heparin prevents clots from forming. Here, in an ST segment elevation MI, The clot has already formed. That's why we use thrombolytics to bust it all wide open. So heparin is to prevent the clots from forming. Glycoprotein 2B3A inhibitors. What's different and unique? Here, catheterized glycoprotein 2B3A inhibitors. These are extraplatelet drugs. Eptifibatide, abscissimab, tirofiban. Eptifibatide, abscissimab, tirofiban. They're extraplatelet drugs. When are they indicated? Non-ST segment elevation MI, worse unstable angina, gonna get cath, gonna get angioplasty. How do I keep you from restenosing? Glycoprotein 2B3A inhibitors in the worst people. Remember, beta blockers are for everybody. Beta blockers are for everybody. But thrombolytics are not. Thrombolytics is not in a person unless they have an ST segment elevation MI. Well, let's see what else is different is nitroglycerin for everybody. So beta blockers and nitrates. But you notice I didn't put nitrates on top. Why didn't I put nitrates on top? Why are nitrates down here? Morphine down here? Oxygen down here? Because morphine, oxygen, nitrates don't lower mortality. Aspirin lowers mortality in all. Beta blockers lower mortality. Thrombolytics lower mortality only in ST elevation. Heparin lowers mortality in both of these. Mortality, mortality, mortality. You bitter hug of mortality, I draw you near. Tell the physician and the priest to go home. If you want me again, look for me under your boot soles. You shall not know who I am and hardly know what I mean. Failing to fetch me at first, keep encouraged. Pausing one place, search another. I stop somewhere, waiting for you. Well, we certainly can see there's a lot of overlap here in between these managements. Well, invasive management is what you do when you have this person who's clotting, right? Well, you have this person who's clotting. And unstable angina is very similar as well. Well, what's the difference between this person here, this? Well, these are a matter of severity. In other words, the person with unstable angina may be clotting off. He's getting worse. Worse pain, new pain, rest pain, worse pain, new pain, rest pain. But the person with a non-ST segment elevation has actually clotted off to the point where they've made troponins. Here, you're slapping me around. Here, you made me bleed. Here, you're hurting me. But here, you're necrosing me. And here, I have an infarction, I'm going to die. This is progressively worse conditions. They all get aspirin, they all get beta blockers, they all get nitrates, morphine, oxygen. ST elevation MI, we just said. Thrombolytics, angioplasty, thrombolytics, urgent angioplasty. But everybody with unstable angina and non-ST segment elevation MI, both of these people should get cathed soon. Why? Because we like to pop that clot open before it gets worse. So that's why it says, you see these phrases here, look at the slide. Early coronary angiography and revascularization. Revascularization means two things. Angioplasty and bypass. Angioplasty and bypass. This is an angiogram. This is a clot. You see it's darker there and it's lighter there? That's because there's more blood here and less blood there. You get a catheter in there, you pop it open. If there's several of them, you pop them both open. If there's three of them, you bypass. You bypass the angiogram. Now, we used to say this term Q wave and non-Q wave. We don't use that anymore because I can't tell if you're going to form a Q wave until 2 days from now. Everything in ischemic heart disease has got to be earlier than that. We can't wait for the Q wave in a day, 2 days, 3 days, 5 days. I got to know now, man. Because I got to go pop you open with a catheter before you develop a Q wave. I'm not going to wait for you to get a Q wave. So the symptoms, wow, look at that. Substernal chest pain, pressure. Do you know that the symptoms of this one is the same as the symptoms of these two? That's what the slide says. It says, the slide says that the symptoms are the same as everybody else. You see this slide? This is a $5 way of saying, oh, it has the same symptoms. Another way of saying this slide, in the Conrad-Fisher way, you could take that whole slide and translate it out to can't tell the difference based on symptoms. The diagnosis. If you don't say EKG, you get sucked out of the test room and shot out on the street. I'm over there with a mouse in my hand. How'd I get here? Because the patient has chest pain. You didn't say they didn't say EKG, man. The symptoms, but the symptoms can't distinguish. The EKG. Remember, these cannot be distinguished without an EKG. Elevation of 1 millimeter. Now here's where we start to refine it. We start to refine it and we say ST elevation. Well, how much ST elevation? 1 millimeter. 2 leads. 1 lead of anything is irrelevant. 1 lead of anything is irrelevant. It also means that you don't need the markers. You don't need troponins and CKMBs to tell you that it's an ST elevation MI. The indications for thrombolytics are not troponins and CKMBs. I can't wait for them. Thrombolytics are good for how long post-chest pain? 12 hours. If the troponins are not going to elevate for 6 or 8, it's too long. It's too long. The other thing is the mortality benefit with these drugs in the first 2 hours, 50%. Your diagnosis is based on EKG, not enzymes. Well, let's hear some rough correlation here. Inferior wall is 2, 3 in AVF. The inferior wall is leads 2, 3 in AVF. The inferior wall is leads 2, leads 3, and AVF. They're like cameras looking up at the bottom of the heart. Well, the lateral leads, like cameras looking at the heart, lead 1 is looking from the side. AVL is looking from the side. V5 and V6 are looking from the side. And where's V2, 4? See this anterior wall here? Where's the anterior wall? V2, 3, 4. V2, 3, 4 are looking at the anterior wall of the heart. Now, EKG correlation with anatomy is approximate at best. EKG correlation with anatomy is approximate at best. We do it mostly because it approximates mortality, and really anything that gives you ST elevation in 2 leads of a millimeter is good enough. This is ST elevation, this is ST elevation, this is ST elevation. That's normal. This is elevation, this is elevation, this is elevation. That's normal. An inverted T wave in AVR, in V1, excuse me, inverted T wave in AVR and V1, in AVR and V1. The inverted T wave in AVR and V1 is normal. ST